All right, so first things first, when we have a difficult airway, we need to know where our equipment is. So we have created our own little kit for the cricothyroidotomy. It's in this little bag, right behind the nursing station, in resuscitation, that sounds like a breathing. And it's in this drawer here, at the bottom, second last. Right here with the rest of the difficult airway equipment. We have another equipment for cricothyroidotomy here, and we have some more equipment down here. We will show you how to do the Bougie assisted cricothyroidotomy. This is the most effective way of securing an emergency front of neck airway, and it's supported by the DAS guidelines, the Difficult Airway Society guidelines. This is the last step of the algorithm. We will do this when we get to KICO. KICO stands for cannot intubate, cannot oxygenate. It's a cute way of saying we're in trouble. So this is what we need. A scalpel, number 10 or number 20. We like this because it has a white blade. A gum elastic bougie, an endotracheal tube number 6, and a syringe. These are emergency situations. We may not have time to disinfect, but if you have time, you can go ahead and disinfect. It is very important to make sure before you do this that your endotracheal tube can be compatible with your bougie and you can thread it easily, like in this situation. What we do not want to happen is to have the bougie in the airway and then to be unable to thread our endotracheal tube because it's too small. We have to make sure that the bougie and the endotracheal tube are compatible before we go ahead with this. And we also want to avoid, for human factors, using equipment that we don't typically use in the ER. So artery forceps, tracheal hooks, trusodilators, Shiley. These are great in practice, but in real life, when we are in a lot of stress, we prefer to use equipment that we've seen before. So now we will show you how to do the cricothyroidotomy. Number one is you go to the left side of the patient if you're right-handed. So you're gonna take your hand, and with your non-dominant hand, you're gonna go on that side of the patient. So I'm right-handed, I'm gonna go on the left side, and I'm gonna try the laryngeal handshake. What does that mean? So between my index and my thumb, I'm gonna grab the larynx up top. This is a big move, not very precise. So I'm grabbing it, I'm rolling it between the two sides. Then I'm gonna move down slowly with my hand, and then with my index finger, whilst still holding the larynx, I'm gonna try to find Adam's apple. Right below Adam's apple, we'll find the cricothyroid membrane. Now in these cases, we won't be able to do that. So what do? With our other hand, we're gonna take our scalpel and we will make a big vertical incision, 8 to 10 centimeters. 1 or 2 incisions should be enough. With this ACE wrap here, it might take a little bit more time or a few more incisions, but that is to be expected. This is not human skin or even the skin that we use on mannequins. So I'm gonna cut. 2 incisions. And now, with my index finger, I'm gonna blindly dissect. If I stay in the middle, I will avoid a lot of the bleeding, but this cannot be a dry field where there's no blood. So I have identified my membrane. Now again with my scalpel, I'm gonna cut vertically this time, away from me, then turn 180 degrees towards me, and then I leave the scalpel in place. I do not move. I change hands. With my left hand, I keep the scalpel in place vertically, and with my right hand, I'm gonna take my bougie, and with the coude tip towards the feet, I'm gonna go where my scalpel is. May not be able to see, but that is fine. Now, my bougie is in place, I'm pushing it down, I remove my scalpel, and I push the bougie down. It should go down to 10, 15 centimeters max, and then there should be hold up. hard stop. It can't go any further. If it stopped at 5 or 6, you might be in a subcutaneous tissue. So 10 or 15, somewhere around there. Then my bougie's in place. We know we're in the right spot. Then I can thread my tube. Make sure that your tube fits into your bougie before you try this. This is a number 6 tube. So in this case, it might be a little hard because of the material that we're using. Some people advocate some muco, but given the amount of blood there's going to be there, you won't have to probably use any muco. So as soon as the balloon disappears, we can stop. We don't need to go any further. We don't want a right mainstem intubation. So now I can remove, holding this in place, holding the tube in place, I can remove my bougie, make sure your tube doesn't move. Inflate my balloon. And we're ready to ventilate and secure the tube. And there you have it. Now, some people advocate cutting the endotracheal tube. It's gonna make, according to them, transport a little bit easier. That depends on you. It's definitely gonna decrease dead space a little bit, but you can do this if you want. What's important is that you got your endotracheal tube.